one of the problems that hospitals face at the moment is being able to get patients through and out of the hospital to create capacity at the front end for emergency provision while maintaining their elective patient flows. And so today we're going to be looking at the computer models that can support patients going through hospitals, how you manage the wards, how you know who's coming in, who's leaving. And our agenda today is really to try and focus on that and to give practical demonstrations of how that works. What I want to do now is to introduce one of our speakers. Lucio has come over from Australia. I met Lucio last October and November time when I went to Australia to join Cumberland AU for a conference, and also to find out a little bit about how the doctors and academics were working there. Lucio, do you want to introduce yourself and tell us a bit about yourself?
Thank you, Terry. Lucio Nacarella is my full name. I'm from the University of Melbourne, specifically the Centre for Health Policy, and within that, the Health Systems Workforce Unit. I'm a psychologist by training, but really I've spent my life really focused on as a health system research evaluator, with a particular interest in health workforce. I have to deal with programs, policymakers, commissioners, key funders, key stakeholders. And I always look for methods or models or approaches that actually engages people. Modelling. I'm a qualitative person. I focus on words, experiences of what people express, particularly at health workforce. But the area of modelling has always kept my imagination. We don't want to just create a transaction just to change overnight. Transformation is about a process. Yep. We need to engage people. So that's a little bit about me and how I see the world.
What I hope we can get out of today's seminar is a sort of a blend of some of the thinking, the very mixed disciplinary thinking, and some of the more established modelling over the course of the day to look at some of the challenges. So let's see how it goes.
What happens is, of course, in this ideal world, we have one receptionist, one nurse and one consultant. And every one time somebody runs, of course, 10 minutes, the person shunts to the next queue and joins that, and so on. So it looks wonderful.
We spend so much time managing today's crisis that we're not really doing enough to anticipate and work out how next week or next month or next year can be different.
So I'm going to run exactly the same model. I'm still going to assume patients arrive exactly 10 minutes. That's, again, in a perfect world, because we know that's not the case. And I've got one of each resource, but now I've got variability in the service times. And now I see queues build. So this is when it's a bit counterintuitive, because I'm still using averages of 10. It now tells me that the typical experience is 2 hours in that system, so no longer half an hour. So from door to door, it's typically a 2-hour time in a system. Some people are still after their 4 hours waiting. So it's kind of mind-blowing, because it said, well, I've still got 10, 10 and 10, but just that introduction of variability, and the mathematics showed that. So I've got variability in service times, and 3 places, suddenly one of each resource doesn't look terribly sufficient.
That's the number of beds that we have, which is that sort of purpley pink block. And this is the distribution of beds that we could have used had they been there. So one of the things we do with this is we run it unconstrained, as if we had unlimited beds, so you can see how many beds you would need.
So we've reached the end of the day. What were the things that stood out for you, Lucio?
Terry, I just want to say thank you again, but specifically with the opportunity to sit down with 2 or 3 people and listen to real world, not just the problems, but how we can look at it through simulation and modelling. I knew a little bit about it before today, but it confirmed to me this is worthwhile, it's desirable, it's realistic, but we've got a little way to achieve it. I mean, some of the problems I experienced as a health system evaluator were confirmed from hearing today. Simulation modelling, those words mean a lot of different things to a lot of different people, and I think we need to engage people, our key stakeholders, our policy clinicians, our junior people. We need to be on the same page to look at what simulation modelling can really contribute. You didn't have to convince me, Terry, but I think you've inspired me, and so thank you again for this opportunity.
Okay, thanks very much indeed.